Um, I'm pleased to be able to introduce today two women who I've worked with on several committees and been at other presentations that they have both done. I think that we're going to find that the information that they're going to provide to us today will be of vital assistance to helping children and families in schools. Sharon Steffen and Nancy Lever, who are both PhDs at the University of Maryland School of Medicine, and they also have several other titles, and one of them is at the Center for School Mental Health. So I will leave the rest of the information as to their positions to them as they speak and introduce them with great pleasure.
Thank you so much, Carol. This is Sharon Steffen and Nancy Lever, and we are really delighted to talk with you all today about mental health in schools. Thanks for the invitation from the Coalition of Families. We'll be talking about the partnership between families, schools, and communities to promote comprehensive school mental health. So, let's see if it works. Okay. Can you all see the slide change now? Okay. Good. Okay, so we've all been hearing a lot in the news and in public discourse since the tragedy in Newtown, Connecticut in December about the need for increased mental health in schools, as well as a message around increased security in schools. And what you see on this slide is actually a quote from an interdisciplinary group on preventing school and community violence that was put out in response to the Connecticut school shooting. Inclinations to intensify security in schools should be reconsidered. We cannot and should not turn our schools into fortresses. And the main message here in red is we need resources such as mental health supports in every school and community so that people can seek assistance when they recognize that someone is troubled and requires help. And it goes on from there. And while this may be a relatively new message for some, the need for increased mental health supports in schools is something that many of us have been researching and advocating for many years. So we'll be sharing a message that our center has shared for quite some time with you today. So I'm incredibly fortunate to serve as the co-director of our National Center for School Mental Health at the University of Maryland School of Medicine, along with my colleague, Dr. Nancy Lever, who you'll hear from in just a minute. We were established in 1995 at the University of Maryland in the Division of Child and Adolescent Psychiatry with funding from the Health Resources and Services Administration. Our mission is to strengthen the policies and programs in school mental health to improve learning and promote success for America's youth. And we have always maintained that the best way to carry out this mission is with a shared family, schools, community agenda. These are some of the wonderful members of our team at the Center for School Mental Health, and we'd just like to acknowledge the contributions that they've made to some of the work that we will be presenting. Our agenda for today is to first define what we mean by comprehensive school mental health and to share some of the main reasons why school mental health is an essential component to systems of care for youth and families. We will discuss the importance of family-school community partnerships to promoting comprehensive school mental health and provide two examples of how school mental health is being implemented in Maryland. And then finally, we'll discuss some future directions for our center and for the field of school mental health in general.
I'm now going to take a moment to share our definition of school mental health so that we are all on the same page. When we think of school mental health, we're not speaking of mental health that is owned and delivered solely by the education sector. Rather, we are speaking about a strategic partnership between schools and community health and behavioral health organizations, always guided by youth and families. It is not a matter of just having a program in the school setting because it's a convenient place to access students. It goes beyond that. School mental health implies the intentional collaboration between schools, families, and communities working closely with one another on teams and in treatment planning. Comprehensive school mental health builds upon existing school programs, services, and strategies rather than replacing what already exists. It involves an intentional building of a system that has a variety of programs and services that addresses the full array of student mental health needs. Comprehensive school mental health is for all students in both general and special education. Every student in the school should have at least some contact with school mental health services and programming. School mental health is not just about serving students with the greatest mental health problems. Rather, it emphasizes a full array of programs, services, and strategies, including mental health education and promotion, prevention, and more intensive intervention. It's important to have a framework that does not just wait for children to have the greatest needs in order to receive any type of support. So to recap, the key components of comprehensive school mental health involve partnerships among families, schools, and communities, builds on existing school programs to provide a full array of services to meet the needs of all students within a school. When we talk about who is providing mental health services in schools, we know that about a third of schools use school-employed staff only, while a little less than a third use outside contracts only, and a little more than a third use a combination of both school-employed and contracts with outside providers such as county and community mental health, juvenile services, and individual providers. The mental health of our students should not fall on schools alone. Along with our school support staff, including school psychologists, school social workers, pupil personnel workers, school counselors, school health providers, including school nurses and occupational therapists, and school administrators and teachers, our community mental health partners must be a part of the equation. Adding community mental health partners to the school support team is critical for several reasons, including their ability to provide a broad continuum of services, from prevention to intervention, 24 hours per day, 7 days a week, to supplement school-employed staff services. And community mental health partners in schools also help to reduce unnecessary, expensive psychiatric services by facilitating connections, referral pathways to community providers for more intensive, specialized services, and providing preventive care that reduces unnecessary, expensive, intensive care. And they also can assist with transitions back to school for more restrictive psychiatric placements.
Great. Thanks, Nancy. This is Sharon again. And I'm just going to turn now to making the case for school mental health. So when we're asked to kind of make the case or argue why mental health is necessary in schools, these are the main messages that we turn to. And I'm just going to review each of these briefly with you. So first, there's what we know intuitively. We know that healthy students make better learners. It is challenging to teach a child who may not be able to focus on their schoolwork. A child who succeeds in school is more likely to be healthy. In fact, there's a tremendous amount of data at this point supporting the fact that a child who succeeds in school is more likely to enjoy lifelong health and mental health. And then next, there is a need. So what's really been a paradigmatic shift in our field is the more recent understanding that child and adolescent mental illness cannot and should not be separated from adult mental illness. So our financing systems and our traditional training programs really separate adult and child mental illness in a way that's somewhat artificial, and we, as a consequence, have undermined progress in the area of prevention and early identification. But what we know is that most mental health problems really begin before age 18, and later onsets are mostly secondary conditions, and that severe disorders are typically preceded by less severe, untreated disorders of childhood and adolescence. So if we think about this from the school building level in terms of need, in a given classroom of about 25 students, 1 in 5 students will suffer from a mental health problem that results in mild to moderate functional impairment. And about 1 in 10 will have moderate to severe impairment. But the other fact that we know at this point is that far less than half of children with mental illness receive the services that they may need, and many services are of poor quality or are inadequate. What many are not aware of is that of those who do receive services, over 75% of youth receive those services in schools. So let's take a look just for a moment at why our children and families are not receiving the needed mental health services in our more traditional community mental health settings. There are several reasons, including financing, insurance challenges, and also logistical barriers, including child care, transportation issues. Families tell us that issues of mistrust and stigma and poor past experiences with the mental health system are also significant barriers. And we don't tend to make it easy for youth and families to access services. We often have lengthy wait lists and tedious, redundant intake processes, sometimes with 1 to 2 hours of paperwork before they can even tell the story of why they're there. One of the most distressing pieces of data is the rate at which families who do make it to children's mental health services never return to services. So this is actually data on this particular slide from a study of trauma services that shows a pretty typical pattern of show rates, with most families not returning after the first session. And in fact, the literature does tell us that the modal number, or on average, families show up for 1 treatment session in the children's mental health arena. So why schools? We know there are several key reasons that schools should adopt and implement school mental health approaches. So clearly, first of all, schools are where the children are located. Most children and adolescents spend a significant time of day inside of a school building. However, the value of school mental health goes far beyond access, and that's a point that we want to make very strongly. We don't advocate for school mental health just because students are in schools. There are many other advantages. So first, there's less time lost from work and school in terms of attending appointments and providing services. We know there's greater generalizability of treatment to the child's context, so we can actually see whether the skills that are taught in interventions generalize to their social context. Schools may be less threatening for children and families as a site for mental health services. Data suggests that school services are more timely than traditional mental health services. Children are typically seen when they need to be seen, not after a lengthy waiting list is cleared and symptoms may have exacerbated. In schools, we have a much greater opportunity to identify and serve youth who may not otherwise be served, including those with internalizing disorders and those who will benefit from mental health promotion and prevention activities. And further, the data is telling us that mental health clinicians may be more efficient and productive than in more traditional clinic settings. And quality school mental health services are demonstrating both cost savings and positive psychosocial and academic outcomes. In fact, the research literature on the impact of school mental health has documented improvements in a number of areas, including behavioral and emotional symptoms, and also on some important educational outcomes. We also have more literature supporting the potential to reduce long-term costs by implementing mental health services in schools, and we've been doing some of this work in Maryland for several years now, looking at the cost savings of providing mental health services in schools. And also, school mental health programs have been documented to help improve service access and to decrease health disparities. So as I mentioned earlier on, our center has always maintained that the best way to carry out effective school mental health is through strong family-community partnerships. And I'm just going to speak quickly to some of the work that we've been doing in this area and some of what we know about parent engagement in schools. So first, the research literature supports the idea that when parents and school staff work together to support learning, students do better on a number of school outcomes. In general, family involvement in schools appears to be linked to improvement in child outcomes all across the developmental spectrum. So really across grades, from preschool to high school, the more parents are engaged in the child's school and in their schooling, the better they do on a number of outcomes, both short-term and long-term. Mary McKay, who's a national researcher in family engagement and children's mental health, has laid out and tested this conceptual framework for the role of parent involvement in schools and has been able to demonstrate that parent involvement in schools actually moderates the relationship between home, family, and school factors and child outcomes. So that is, when parents are involved in schools and when it's promoted in a positive way, children do better. So there are some very clear reasons why families may be apprehensive about engaging in schools, both in schooling in general, but also in school mental health services. And these are some things that we've been factoring into our training for several years now. So they may have received mostly negative feedback about their own children. The calls they get are about negative behavior versus positive. Some families or parents may not have done well in school themselves and so may be reluctant to engage. High staff turnover in the schools can make it very difficult for families to actually build sustaining relationships. And also families are often not sure how to become more involved related to lack of communication from the schools or from mental health providers in the schools. So these are really clear barriers to engagement. There's also been research on the factors that may limit family engagement in school mental health both in urban and rural settings, and some of these are laid out here. Mary McKay actually spoke with a number of families across settings to better understand what may prevent them from engaging in school mental health services, and these are some of the barriers that the families reported. So not only some logistical barriers and stress barriers, but also attitudes about mental health, stigma, and previous negative experiences with the system. These issues were also reported by families in rural settings, but they, in addition, reported things like concerns about confidentiality and isolation. So our Center for School Mental Health has been following Mary McKay's work and her model of better promoting family engagement, starting from the very first contact with families. And we've been providing some training around this and are doing some research on this area in the area of school mental health in particular. So one of the things that we've been working on is training our school mental health clinicians in McKay's 4 goals of the first phone call. So the first being to clarify the need for mental health care, increase caregiver investment and efficacy, identify attitudes about previous experiences with mental health care in institutions, so taking the time to ask about their prior experiences, and then really problem solving on that first phone call around concrete obstacles to care. And we have a more lengthy protocol that goes into details, but this is just kind of in summary what our training covers. And this is one particular telephone engagement study where they utilized some of these components. And what they found was that simply by implementing some of these components during the first phone call with families, they were likely to decrease the show rate significantly. So the number of families that actually showed up to the first appointment was significantly higher for the group that actually used some of these first phone call strategies. We've also been training our school mental health clinicians in McKay's critical elements of the engagement process, so beyond the first phone call. I'll just walk you through these very quickly. So first of all, the elements that we've been training clinicians in is clarifying the helping process for the client, so really carefully introducing the clinician, the agency intake process, and possible service options, not assuming that the client or family has been given accurate information about services, and not assuming that clients or families know what's expected of them or what they should expect from the intake process or the intake worker. The second element that McKay has guided us to provide training in is to develop the foundation for a collaborative working relationship. So really balancing this need to obtain intake information, including insurance forms and agency assessments and all the things they collect during a first and often subsequent sessions, but really balancing that with helping the child and family to tell their own story and why they have come. The third element we've been providing training on is focusing on immediate practical concerns. So really be ready to schedule a second appointment sooner than the following week. Families may need help negotiating with various systems, not just with that particular system they're entering, and responding to families' concerns about providing an opportunity to demonstrate commitment and capacity to help. So really encouraging clinicians to demonstrate their commitment in those early sessions. And then finally, identifying and problem solving around any barriers that may exist to help seeking. So as we talked about, asking them about what their potential barriers are, specific obstacles and like transportation and time, but also other barriers such as previous negative experiences, discouragement by others seeking help, and so forth. And what McKay has found, and we've been studying as well in our own programs, is the result of using some of these elements and of training our clinicians in these elements. And as the graph demonstrates, families are more likely to continue to engage in treatment when clinicians have actually been trained in these specific engagement strategies. So this is a really promising approach, not only for school mental health, but really for mental health in general. And I'm going to turn it back over to Nancy, who's going to share a couple of examples of school mental health in Maryland.
Okay, thank you, Sharon. I want to provide some examples of successful school mental health programs and initiatives just to give you a better sense of what it is we're talking about, to give you a sense of what it looks like at the local level. The first initiative I will describe involves the U.S. Department of Education Safe and Supported Schools grant that was awarded to the state of Maryland beginning in 2010. Maryland was one of 11 states awarded the 4-year grant. Partners in the Maryland Safe and Supported School Initiative, referred to as the MDS-3 initiative, includes the Maryland State Department of Education, Shepherd Pratt Health System, Johns Hopkins University, and the Center for School Mental Health at the University of Maryland. The initiative provides the opportunity to formally connect student achievement with the other conditions that we all understand are necessary for learning. More specifically, school climate specialists work with the schools in the 9 counties participating in the project. The counties that are involved in the project are Anne Arundel, Baltimore, Charles, Caroline, Dorchester, Somerset, Washington, Wicomico, and Queen Anne's counties. As part of the project, climate specialists help to formally assess school climate, student engagement, and the school environment. They assess mental health needs and work with the school to implement evidence-based programs to address the needs such as reducing school violence and substance abuse while working with the schools to improve conditions to support learning. All of the MDS-3 schools that are part of the project are high schools. Key components of the MDS-3 framework include positive behavioral interventions and supports, database decision-making, a 3-tiered public health prevention model to address the needs of all students, coaching, and a focus on community support. This slide shows some sample questions from the MDS-3 School Climate Survey, just to give you a better sense of the type of questions used to assess school safety, engagement, and environment. So questions such as, I feel safe at the school, I feel like I belong, and the school has a bright and pleasant appearance. For those who are interested, we have listed some of the evidence-based programs that are being implemented as part of the MDS-3 project. Each climate specialist works with the high schools involved in the project to identify the programs that are most relevant to the student needs, and then they select which programs would be implemented within the school. Moving on to our second example of school mental health in action, we often get asked, what does it really look like at the ground level? Our answer is that school mental health varies tremendously in terms of its appearance at the ground level and is really adapted to meet the unique needs of each school and each district. To give you some frame of reference, I'll touch on a program we operate out of the University of Maryland School of Medicine to serve students in Baltimore City Public Schools. Our Center for School Mental Health works closely with the program to inform them about best practices in the field, and our program's clinicians, students, families, and school staff help to inform our Center for School Mental Health about what is really needed and what truly works in schools. The University of Maryland School Mental Health Program is part of the Baltimore City Expanded School Mental Health Network. Within the network, there are 4 primary providers, and our university is one of the 4. We currently serve 27 schools, including elementary, middle, and high schools. Schools that we work with are predominantly serving youth from low-income, highly stressed communities. We provide a continuum of mental health promotion, prevention, and intervention within the school, working most closely with youth in general education. Our team is multidisciplinary, with clinicians including social workers, psychologists, licensed counselors, and a large team of graduate trainees. We also work closely with psychiatrists from the university. One of the reasons for the success of the ESMH network has been its use of blended funding. No one source is fully responsible for funding the programs, and together they can support a larger initiative. Having a commitment from multiple funding sources toward a common goal is cost-effective and improves the coordination of the needed services. So in Baltimore City, we have blended funding to support school mental health services from Baltimore Mental Health Systems, the Family League, Baltimore City Public Schools, as well as Baltimore Substance Abuse Systems. We often get asked, how do clinicians actually spend their day? This slide shows an approximate breakdown of how their day is spent. So we would estimate that 10 to 20% of their time is spent doing broad environmental improvement, mental health promotion, really acting as a change agent within the school. 50 to 60% of their time is spent doing prevention and early intervention, so they're really in this prevention specialist role, while only 20 to 30% is spent on intensive assessment and treatment, and that's more the traditional therapist role of individual, family, and group counseling. Moving on to talk about school mental health training. Within our program, we have a strong emphasis on training and rely heavily on our trainees to carry out quality mental health services. We train mental health providers from a variety of fields, including nursing, social work, psychology, counseling, and psychiatry, and we are working with trainees from high school to college to graduate and to postgraduate levels. The Center for School Mental Health and our University of Maryland School Mental Health Program are committed to training our future workforce to understand how to effectively work in and with schools to provide a full continuum of quality school mental health services. We really do believe that to work in schools, specialized training is really needed to understand how to do this work most effectively. One group that we have trained very closely is our psychiatry fellows. We have our psychiatry fellows complete year-long rotations in our Baltimore City schools. For many, this is their first experience in a school and the first time they are really seeing the communities our children live in. So we believe whether they continue to do work in schools or work in other agencies and programs, it really provides some knowledge that is helpful that will stay with them as they do their future work. In terms of the amount of time that we spend with our psychiatrists, we also, in addition to their face-to-face time that they have in our Baltimore City program, they also work with another one of our programs providing telepsychiatry services. So they connect with our clinicians using the telepsychiatry equipment to provide some consultation. In addition to our school mental health program, we have two other programs, one in Prince George's County, one in Baltimore City, that are serving students predominantly in special education and at risk of more restrictive educational settings due to the mental health issues. The Prince George's program was established in 2006 by the state and local educational authorities based on concern over high rates of referrals to non-public schools, racial disproportionality, and high costs of non-public placements. In 2009, Baltimore City established a similar program based on the success of the PG initiative. Both programs augment existing services with therapy, case management, and psychiatric consultation and intensive family support in the Baltimore City program, including a partnership with the Maryland Coalition of Families to find a family support partner to work with the clinicians, schools, and families that are part of the initiative. One program that we do not have a slide up for but has very much been important in our work at the center is we are providing school mental health services in Anne Arundel County, and that program is sort of a blend between our traditional Baltimore City program serving general education students and our Prince George's and Baltimore City school mental health initiatives that are working with high youth with more intensive mental health needs.
Great. So this is Sharon again, and I'm just going to touch on a few other areas where our center is focused and where we believe the field is moving in the future. So within the programs Nancy just discussed, as well as within our national work, we focus on four major themes with respect to providing quality services. And part of this really came out of some NIMH funding that we've had over the past 2 years on how to advance quality in school mental health. And I'll just touch on each briefly. So first, quality assessment and improvement. Over the past 2 decades, we've really worked to establish a set of guiding principles on quality school mental health. And we've developed associated quality assessment and improvement instruments and procedures for programs to work on achieving higher quality along these dimensions. And these are principles like including emphasizing access to all youth regardless of ability to pay, the emphasis on quality and empirical support, etc. These are a couple of the tools that we've developed and have contributed to that measure school mental health quality and provide a QAI, or Quality Assessment and Improvement Framework, for planning. We've also seriously ramped up our efforts over the past few years around meaningful partnership with families, and our work with the Coalition of Families over the years has really contributed to this effort. So we've been incredibly grateful to have that partnership, both at the local level as well as at our national level. And we've had Susan Taker as a member of our advisory board for several years, as well as partnered with Jane and Angela Von Lee. So we've been really fortunate to have those partnerships inform our work. We've also gained a lot of information and insight from researchers in the field, including Mary McKay and Kimberly Hoagwood, who have worked with us to really infuse the emerging literature and specific practices for meaningfully engaging families and children's mental health treatment. Because if you really look to their literature, it becomes obvious that this is one of the biggest failures of the field of children's mental health and likely one of the contributing factors to the fact that families are only typically showing up to one treatment session on an agency-by-agency basis. So another area that we've put significant attention toward is infusing evidence-based practices into school mental health work. And we've done this both with respect to manualized or packaged interventions as well as what has been called modularized or kind of this common elements approach. So in this particular figure on this slide, we list some of the evidence-based packaged interventions and programs that we use across the continuum of care in our own school mental health programming. And we've also been doing significant training over the last several years on implementing common elements of evidence-based practice into our school mental health work. Finally, our center has been placing more emphasis on implementation support, so we've moved beyond the idea of train and hope models for professional development and have really encouraged school mental health programs nationally to do the same. Our center has worked closely with leaders from the National Implementation Research Network, Dean Fixon and Karen Blase, to introduce more interactive and lively teaching, often on-site coaching, performance assessment and feedback, emotional and administrative support, peer-to-peer support, and user-friendliness of training materials. In addition to those four areas, I just wanted to mention a couple of other areas where we believe the field is moving and our center has been partnering on. So first, we continue to be invested in building capacity within all child-serving systems, including education. And we worked on a 5-year CDC cooperative initiative with our center as well as the National Assembly on School-Based Healthcare, where we've developed training modules for state and local education agencies to be able to build their capacity around school mental health. And those are all available free online on our center's website. And we've been partnering with several states, including some of those listed here, to use the modules and advance school mental health capacity. School mental health is also a critical player in our discussion of the role of schools in primary care mental health integration. This is a particular research interest of mine. We've worked with the National Assembly of School-Based Healthcare for a while and more recently now with the National Association of School Nurses to improve the mental health competencies of school health providers, who are often the individuals on the front lines of mental health care for our children. Schools are really well positioned to serve as medical homes for many children, particularly schools with comprehensive school-based health centers. We already know that school mental health professionals are supporting many substance use prevention and intervention programs in schools, and there's a wealth of opportunity to enhance their involvement in the area of substance abuse prevention and intervention. And one of the most compelling areas for this, we believe, is the area of co-occurring trauma and substance use. So with considerable work of the National Child Traumatic Stress Network, schools have made significant progress in developing evidence-based interventions to address trauma in schools, but we would argue there's still a long way to go with respect to implementation. And we have an even farther way to go to adapt these programs for use with co-occurring disorders, and this is an area that our center has been focused on. We'll continue our work on enhancing the competencies of both mental health and education workforce. So a couple of examples of this. We've been co-teaching a course. Nancy Lever from our center, along with Michael Lindsay at the School of Social Work, have been teaching a course on interdisciplinary school mental health at the graduate level. And I can brag that for Nancy and Michael that this has been the highest ranked course for a number of years in the School of Social Work. And, you know, I think folks really feel that it's an essential component of their workforce development if they are to work in schools or just work with children and families in general. We've also been working in partnership with the Maryland State Department of Education and have developed an online curriculum on mental health competencies for educators, which is being vetted as we speak and will be up online shortly. There's also tremendous potential to better connect school mental health to other child-serving systems, including child welfare and juvenile services. Our center has done some work to that end, including developing a free training curriculum to better connect school mental health and foster care, developing an issue brief on the role of school mental health and school reentry following juvenile detention, and active participation in the Juvenile Justice Dropout Prevention Practice Group within our national community of practice, which Nancy will mention in a minute. I won't go into great detail about this, but we have been going in depth in our work in the military, and school behavioral health has become one of the largest growing components of mental health systems within the military. We helped develop an operations manual that's being installed in a number of military installations across the country and internationally, and there's also a grant that our colleagues have worked on in terms of building capacity to create highly supportive military-connected school districts. And we've been partnering with the Maryland State Department of Education and others in the state of Maryland to also advance this work. Finally, we see a tremendous area of growth in the area of technology-assisted treatments, including telephone-based cognitive behavioral therapy, texting, smartphone apps, avatar, telepsychiatry, number of areas, and we've, again, been working with the Coalition of Families and the state's youth leadership organization to advance some of this work. So finally, with the President's call for increased attention to protecting our children and communities, our center has been asked to focus on some of the bullets that are laid out in the administration's action plan, which are listed here. These have to do with developing universal systems for assessing school climate, mental health, and outcomes of comprehensive school mental health, partnering around youth mental health first aid, specifically adapting this for teachers, school and school district training on a number of different areas, including trauma and violence prevention, and then interdisciplinary training for school-employed and school-based mental health, community mental health professionals.
Okay, finally, we'd like to leave you with a few resources that you can have at your fingertips. We realize that people are very busy, so one of the things we try and do at the center is to make our resources readily available and very easy to access. So we developed schoolmentalhealth.org that has a wealth of free practical resources for clinicians, educators, families, and students. There's fact sheets, newsletters, PowerPoints, community directories that can be used directly or easily adapted to best meet your needs. Please feel free to use whatever you'd like and steal all you want. We also through the center, help to sponsor a national community of practice on school behavioral health. We have partnered with the IDA partnership to host a national community since 2004. This community convenes at our annual conference that also has ongoing activities throughout the year and goes deeper into specific topics via a practice group model. We have 12 practice groups that focus on specific topics of interest, but especially relevant to today's webinar is there is a practice group on families and partnerships with schools and communities. And there's also one on quality and evidence-based practice. For more information, please visit sharedworks.org. Also, we're very excited that our annual conference this year will be held October 3rd to 5th, 2013 in Crystal City in Arlington, Virginia. And, with it being so close by, we hope that many of you will be able to attend. This is really the nation's premier interdisciplinary comprehensive school mental health conference, and we hope that we'll get to see you there. This last slide just shows our contact information, and honestly, please feel free to contact us if you have any questions. We're happy to discuss things further with you, and hope we'll hear from some of you. We did put up a few questions. There is a polling mechanism, and Adam from the School of Social Work is hopefully going to help us out, and magically questions are going to populate.
Let's see. Are you there, Adam? So I believe that Adam is going to go ahead and put up a few questions that folks were going to be able to respond to.
And this is meant really as an opening to everyone's
questions.
There we go. Our first one. There it is. Okay. The first question is, would you be comfortable accessing mental health services for your child in a school setting? Yes, no, we're not sure. And it could be for your child or for a child that you're working with or you know the family. Would you recommend school mental health services?
I think you can go ahead and answer that online.
You'll have 30 seconds. Okay, the poll has closed, and
because I'm like, look, nip that in the bud. It's right.
I'm not sure folks can see this on their line or not. Adam, we can't hear you. I'm not sure if it's working from your end. If not, we can just go on to Q&A.
Okay. Yeah, it's working. So I had 10 out of 32 people said yes. 0 said no, and then 1 out of 32 said not sure, and then 21 didn't answer.
Okay. So people who are answering, it sounds like most people would be comfortable accessing the services. Moving on to our next question. Do you believe that the amount of school mental health services available in your community is adequate to meet the mental health needs of students? So the responses can be, we have all the needed services, we have services that need a lot more, we have services that need a little more, or we do not have services. Please take a moment to respond, and then we'll discuss the responses.
Good. Don't you?
Okay, Adam, do we have the responses?
Yep, it's just going to take a little bit to generate the responses.
Okay, no, we're happy to have you helping. Feel like it's a game show of sorts.
Psychiatric services.
Okay, 0 people responded A, 15 for B, 3 people said C, and 1 person said D.
Okay, so it sounds like, overall everyone is saying that we need a lot more services and that no one's having the struggle that we have enough. Right. So school mental health service, we need more out there. Let's go to our last of the questions that we're posing before we open up questions to the group. And so the third question is, have you accessed mental health services in school for your child or helped others to access them for their children? Yes, I have accessed school mental health services, or no, I have not accessed school mental health services. We really just wanted to get a sense, to give you an idea and get a sense of what your experiences have been. Okay, and let's turn things over to Adam. Adam, do you have the responses and the tally says?
All right, we have 16 people said A, 2 people said no.
Okay, that's really exciting that people are accessing school mental health services. Clearly, this is a very informed group and aware about what's available.
Okay, so why don't we go ahead? We were asked to leave a few minutes for Q&A. So if folks have any questions, we'd be happy to answer them. And Adam or Carol, I'm not sure how this works. I think you instructed folks to unmute themselves or to raise their hand.
Does anyone have any questions?
We have, somebody had their hand up and then they took it down.
Don't be shy.
Here we go. Have, who is that? Bernadette Street.
Okay, Bernadette.
Bernadette, if you unmute yourself by pressing, *6, Adam?
Oh, can you hear me?
Yep, we can hear you now.
Terrific. Your presentation was so awesome. I appreciate it.
Thank you so much.
We did not. Thank you.
Sorry.
Fine.
Oh, you're welcome. I have 2 questions for you. One is I couldn't copy fast enough some of the resources. I'm wondering if you would agree to make available the slide presentation to us. I'm not sure if that's even possible.
It is. So I think this will be in one of 2 locations. So first of all, I know that the School of Social Work posts all of their PowerPoints from their webinars onto their website. We also post ours on the Center for School Mental Health website, which is listed on the slide that's up there right now. So it's csmh.umaryland.edu. And if you just Google Center for School Mental Health, you'll find us as well. So we will go ahead and post that up there today.
Yep, we're happy to do that. Also, if you send either of us an email, we're happy to send it to you directly as well.
Oh, you're so sweet. Thank you.
The
second question
Sharon
is,
and Nancy, this is Carol, you can just send it to me, and then I'll send it out to the participants if that's easier for you.
Perfect. That works well. Thank you, Carol.
Okay.
my second question to you is there any training available on the engagement interviewing process that you stated? Because it is the first contact in general with parents is so critical. Are there any trainings available for that? And is it the kind of training that you could do in a 1 or 2 hour webinar, or no?
So it's a great question. We have done it in the context of a couple of different projects. We've done it with our own school mental health clinicians as well as part of a couple of research studies. And we have kind of different forms of the training. So some we have delivered in a brief format, for example, that could be done in a 1 to 2 hour training. Now, clearly, in order to enhance the likelihood of the skills generalizing to practitioners' use. So, we would prefer to do it in a format where it allows the opportunity for practice and role play and coaching, which is how we've done it with our own clinicians. So we really have both formats available. We also have a couple of faculty here in the Division of Child and Adolescent Psychiatry, Nicole Brandt and Kim Becker, who actually have a project right now where they are going to be recruiting a number of mental health providers across the state to be doing this training with them, to be actually participants in a project they have going on to do the training. So I'd say there are a number of different possibilities, and if you are interested, feel free to contact Nancy or me, and we'd be happy to give you more information.
Okay, that sounds great. Thank you so much.
Any other questions?
Hey, I don't see any other hands up. So if nobody else, I have a question that I would like to ask. It's not really a question. I was interested to see that primary care and mental health, the slide about primary care and mental health integration, with having schools as a medical home is in the future. And I think that's a terrific idea. I think there are a couple of sites in the state that are doing something similar to that in Montgomery County at Northwood. Is that what you're looking at? Is that the idea of that?
So there's a number of school-based health centers across Maryland, over 60 at this point, and maybe over 70. There's been
74.
74. Thank you, Nancy.
I just looked at that the other day.
So, and both in Maryland as well as nationally, folks are looking at the possibility of those really serving as medical homes. And for just over 2/3 of school-based health centers nationally, they provide comprehensive school mental health services as part of their school-based health center. And so some of the school-based health centers really provide what we would think of as comprehensive health and mental health services, some including oral health as well as physical health and mental health services. So we'd be happy to provide more information about that model, but a couple of good resources would be the Maryland Assembly on School-Based Healthcare, as well as the National Assembly on School-Based Healthcare, both of which have websites. The Maryland Assembly on School-Based Healthcare has their upcoming spring meeting and conference on May 16th, and so I believe they'll be discussing that topic as well.
And we do want to respond. It looked like in the chat section from Lauren, there was a question asking, are we in support of the elimination of the use of aversive intervention, seclusion, and restraints? And I can say that through PBIS and school mental health programs, we are definitely looking for more positive ways to address behavioral concerns. And in our schools as well as at the state level, that clearly has been a priority. And I know the coalition has been very involved on many of those committees at the local and state level, and our center very much supports any effort to reduce any adverse intervention.
Thank you.
You're welcome.
Any other questions?
I don't see any. Okay. Well, I will then thank you both on behalf of the Maryland Coalition, our families, our participants, and I feel, and I think Bernadette said as well, is that this was an awesome presentation. It will be of great use also because it'll be available to others to view. So I thank you so much. We greatly appreciate your participation and your sharing of your insights and your knowledge and your experience. Thank you.
My pleasure. Thanks for inviting us to share. Take care, everybody. Have a great afternoon.
And thank you, everybody, for participating. I'll be sending out a brief evaluation and ask you to complete it and get it back to me so that we can continue doing these. And we will be in touch with information about our next webinar. Thank you.
Thank you.
Bye-bye.